Good afternoon, everybody. I'm Dr. Vijay Negalur, consultant diabetologist at Jupiter Hospital and having a practice clinic at Thane. Today, I would like to discuss with you a newly diagnosed type 2 diabetic patients with a high baseline A1C level. How do you manage such kind of patient? So let's see this patient, 45 years old male patient, newly diagnosed with type 2 diabetes, visited the clinic 6 months back with a multiple risk factors like obesity, hypertension, dyslipidemia. He was initiated with metformin with the advice of lifestyle and a diet modification. Recently visited again as a part of routine checkup, and his lab evaluation showed that A1C was still 8.5%, eGFR was 80 ml per minute per meter square, LDL was 80, HDL was 38, and triglycerides was 300. He was on medication like metformin 1000 milligram BID, lisinopril 40 milligram once a day, metoprolol 100 milligrams once a day, atorvastatin 40 milligram once a day, and aspirin 75 milligram once a day. The examination revealed his BMI of 31 kilogram per meter square. His BP was 120 by 70, and his heart rate was 78 per minute. The evidence indicates that the early intervention and achievement of glycemic control reduces the long-term micro and macrovascular complications in type 2 diabetes. UKPDS demonstrated legacy effect of early intensive therapy because the difference in the CV events at the 10 years post-trial was apparent even though the A1C levels between the intensive and the conventional therapy was similar. When metformin is not suitable or contraindicated, empagliflozin or linagliptin is being considered as an alternative first-line treatment. Initial combination therapy may be considered to achieve target more quickly, particularly in patients with high baseline A1C level. So early combination therapy in type 2 diabetes makes clinical sense for several reasons. First, a meta-analysis showed that the early use of combination therapy significantly increases the likelihood of achieving the glycemic targets below even 7.7% with metformin monotherapy. For patients with A1C more than 1.5% above the goal at diagnosis, American Diabetic Association and European Association Study of Diabetes guidelines recommend first-line treatment with a dual combination and an SGLT2 inhibitor as the first post-metformin treatment in patients established cardiovascular disease, congestive heart failure, or a chronic kidney disease. EMPA-LINA combinations with the complementary mechanisms and the pleiotropic benefits may be suitable option across a range of patients, including those with the established atherosclerotic cardiovascular disease or a high risk or established heart failure or a chronic kidney disease due to the tolerability of the combination, in addition to the potential benefits of empagliflozin on the CV and renal outcomes, and no increased risk of a heart failure with the either agent. According to the study, early achievement of A1C goal less than 7% with EMPA-LINA could reach the target of A1C at 12 weeks compared to monotherapy. So therefore, A1C decrements by EMPA-LINA, that is 25 milligrams of the empagliflozin, 5 milligrams of linagliptin, has demonstrated about 1.9% reduction in A1C when the baseline A1C was more than 8.5% at the end of 24 weeks in the metformin-treated groups. This was a study done by Julio Rosenstock. The benefits on the glycemic control were maintained at the weeks 52 in the metformin-treated groups, and a higher percentage of patients achieving the benefit of having A1C less than 7% were reported in the combinations therapy. So therefore, the combination offers a suitable component in the strategy to achieve target A1C without increased risk of hypoglycemia and the weight gain, which are important deterring factors in the treatment of type 2 diabetes, and also showed a good profile of the lipid levels. A reduction in the incidence of genital infections, especially when you co-prescribe the SGLT2 inhibitors with linagliptin, has been reported by Fadini et al., and who looked at the genital infections, which was much less when you combine these two medications, probably because the DPP4 inhibitors are effective in preventing the multiplication of bacteria and fungi, because they also have DPP4 on their in their structure, so that DPP inhibitor inhibits their growth. And secondly, with the good glycemic control, the immunity is well regained and the patient does not have the genitourinary infection that you otherwise see when you use a monotherapy to treat patients of diabetes. And furthermore, the SGLT2 receptors and the DPP4 receptor are both located outside the cell. So therefore, when you have a drug which works on both these receptors like SGLT2 and DPP4, maybe the additive effect is beneficial in preventing the genital infection. So therefore, this combination offers an extra benefit in reducing the genital infections. So just to summarize this case, the empalina combination provides robust A1C reduction and 2 to 4 times higher odds of patient achieving the goal of A1C compared to individual agents with no risk of hypoglycemia and weight gain. With that, we conclude this case. Thank you very much, Purvi. I conclude my talk.